Hello, my name is Rachel Sayre, and I'm the Heart Disease and Stroke Prevention Coordinator for the South Dakota Department of Health. And I'd like to welcome you to this webinar, which we will discuss patient-centered medical homes, Medicaid health, and other forms of team-based care. This webinar is being recorded and will be posted online, so it may be referenced at a later date. If you have any questions or comments, please feel free to type them into the chat box. Also, you can download a PDF of the slides in the handout box below. One more thing, the lines are muted, so just press *6 to unmute them. And you can see that Mallory made a note of that in the chat box as well. Before we begin, I'd like to tell you a little bit about why this team-based care webinar series exists. In January of 2016, about 24 healthcare professionals began developing a strategic plan for statewide cardiovascular health. It was finalized and implemented in 2017, and the current version of this plan is what you see here. It can be found on the South Dakota Department of Health's website listed at the bottom of your screen. During the process of developing the strategic plan, 4 different goal areas were identified as denoted by the different colored columns. Each of the 4 goal areas has a work group working toward that area's designated strategy. The first thing the priority populations group decided to focus on was promoting different models of team-based, patient-centered care. When gathering some background information for the strategy, we realized that team-based care is still a relatively new and underutilized concept for South Dakota. And there's still a lot of uncertainty as to what's considered team-based care, what different team-based care models are out there, and how team-based care can be incorporated into our rural healthcare environment here in South Dakota. So as a result, the Priority Populations Group decided to develop educational resources, including a toolkit and this webinar series that focus on team-based, patient-centered care, and that meet the specific needs of South Dakota's healthcare professionals and organizations. During that resource development, we found that in South Dakota, there are 2 main models of team-based care being implemented, and the first of which is our South Dakota Medicaid Health Homes model. Today, Kathy Mueller will give us an overview of the Health Homes program, including the core services and program eligibility, as well as some information on outcomes and success stories. So Kathy Mueller is a program manager for the Department of Social Services, Division of Medical Services. She works primarily with the South Dakota Medicaid Care Management Program, such as the Health Home Program and the Primary Care Provider Program, and was part of the team of state and non-state stakeholders that helped to create the Health Home Program. She previously worked as the State Registrar of Vital Records for the Department of Health and served as the Senior Advisor for Health, Human Services, and Social Services for former Governor Rounds. Thank you, Kathy, and I will turn the floor over to you.
Thank you, Rachel, for that kind introduction. So as one of the models of team-based care, I want to share with you information about the Health Home Program. The Health Home Program started back in 2013, and it was an initiative that was a part of the Affordable Care Act that South Dakota chose to adopt because we found that about 5% of the individuals within Medicaid created more than 50% of the costs in our Medicaid program. And so the Health Home Program, as it was designed by the federal government, is a systematic and comprehensive approach to delivering both primary and behavioral health care together that typically promises a better health experience and better results than traditional care. And it's really designed to affect change in the health home recipient's health status and reduce utilization of high-cost services such as inpatient stays and emergency room usage. As part of this program, the federal government requires us, or the providers, to deliver 6 core services. Those are specifically outlined, and we will talk about them later, by CMS, but we actually, as part of the Health Home Work Group, defined them. And they must be provided to each of the health home recipients that are on the program. So let's take a little bit better look at what that means. So really the goal for this program for us was to coordinate the care of Medicaid recipients who have high need. And so twofold, reduce the cost of care for these recipients while in turn improving the health outcome of these recipients. So who do health homes serve? Health homes are any Medicaid recipient, and this Medicaid recipient can be individuals who are being served with, also have another form of health coverage like Medicare or private health insurance. As long as they have eligibility for Medicaid, they are eligible. And they have to have 2 or more chronic conditions or 1 chronic condition and an at-risk condition. And those are defined separately, and you can see there below. So for example, chronic conditions that make an individual eligible, you could have 2 of these, some form of mental illness, substance abuse, asthma, COPD, which is one of the areas that we spend a lot of time focusing on, diabetes, heart disease, hypertension, obesity, musculoskeletal, and neck and back disorders. Or you can have one of those conditions and one of these at-risk conditions: prediabetes, tobacco use, cancer, hypercholesterolemia, depression, and the use of multiple medications considered as 6 or more classes of drugs. All by itself, one severe mental illness or emotional disturbance also makes you eligible for this program. So how we determine the eligibility of individuals within Medicaid for this program is we send on a monthly basis 15 months worth of claims history, and our vendor looks at whether or not they have the ICD-10 codes related to those diagnoses listed above. And then once they're determined eligible, we use, or they use, a algorithm called the Chronic Illness and Disability Payment System to tier them into one of 4 tiers. The higher the tier, the more severe the illness that that individual has, or the more need they have for coordinated care. So there are 2 types of health homes within South Dakota, and they're based around those specific conditions. So the primary care is a group of individuals, so primary care, so that there's a designated provider within the primary care clinic. And it can be a primary care provider such as a doctor, a physician assistant, an advanced practice nurse, and they need to work in a federally qualified healthcare center, rural health clinic, group practice, or Indian health service. And as part of that, they also create a team that helps work with that recipient based on their needs. So in all cases, there's some sort of a care coordinator or health coach as part of that team. You could have a pharmacist. There could be a support staff or other appropriate services. For individuals on one of our waiver programs, it could be their case manager. And so the other type is then individuals who are served through the behavioral health programs. And so the designated provider there is defined as a mental health provider that works in a community mental health center. And so the community mental health center as a whole will be that individual's designated provider. And so you have these 2 groups of individuals that work together. And what we found is having those 2 groups work with an individual recipient, that oftentimes we see that their care and their ability to access primary care, especially those individuals who have a severe mental illness or emotional disturbance, tends to improve. And by improving access to primary care for those individuals, we tend to see improved results. So I want to chat with you quick about what the 6 core services are. If you remember, I referred previously to the fact that CMS said what these 6 core services need to be, but we worked with our work group to help define them. So we have to provide those 6 core services as appropriate to all enrolled recipients. Health homes are paid a monthly per member per month for the delivery of this core service. And it's 1 core service per quarter. So the payment is a retrospective payment made on a quarterly basis. So currently, the quarters are standard quarters. So right now, we're working on quarter January through March. And they have all of April to determine or provide us information about whether or not they provided a core service. And then, if they indicate yes, and that recipient was in their health home for all 3 months, they get paid for that per member per month payment for all 3 months. And the per member per month payment is anywhere between $9 and $250. And those have recently increased, and so I think that's not quite right. But you have to have a core service, and we define a core service as the recipient should be engaged in an action. So it simply can't be a provider care conference where you talk about that. The recipient actually has to be part of it. The core services are specific to the patient and tied to their care plan. Every recipient in this program should have a care plan, and that it's documented in the electronic health record. You can provide all of the core services that you want, but if it's not in their electronic health record, it didn't happen. So I'm going to chat through with you what some of those core services are and what they mean. So one of the core services is comprehensive care management, or that's the first one. And so we consider this that development of the individualized care plan with active participation from the recipient and the health home team members. Then we move on to care coordination. So these are just very brief descriptions. There is a more detailed description of each of these core services that they can be accessed on our website, and I will give that later. Care coordination is then taking that care plan and implementing it. So making sure that all of their referrals and linkages are in place, as well as following up with their needed services and support. The third one, health promotion, is the one that a lot of individuals use. It's really taking that individual care plan, understanding their conditions, and helping support their ideas to motivate them to adopt healthy behaviors. So for example, for cardiovascular, it can be referring them to the Better Choices, Better Health program, or to the Quit line or anything associated. It can be connecting them with resources within their community to help them better manage their health care on their own. This first one on this slide, the comprehensive transitional care, is really the most challenging core service that we find, but really the most important thing that we can do to help our recipients stay out of the ER or out of the inpatient stay. So health homes are required to do a follow-up either visit or phone call with their recipient within 72 hours after an ER visit or a hospital stay. And that phone call can be something as simple as, did you get your medication? Do you understand your discharge instructions? Do you know when your next appointment is? Do you have a way to get to your next appointment? So those are the types of things that we want to make sure happen with those recipients so that we can keep them from readmitting to the hospital or continuing to go to the ER when it's not necessary. So the next one then is recipient and family support services. And so we really like the health home to try to engage all members that support that recipient in the program and to help to reduce that recipient's care coordination. To help reduce the barriers. And so really working with them. So if it's a recipient that has issues with their blood sugars, is there someone that can help make sure that their medications are in their box as appropriate? Really using as much of the family and caregiver support that we can. The last one is really understanding what's in their community and making appropriate referrals. So in some instances for recipients, it could be they need legal help, or they need housing, or they need food, or they need transportation. And that's where these types of work that care coordinators do with recipients fall. It falls under this specific core service. So currently we have 127 health homes that serve 131 locations. So how that breaks out is we have 24 federally qualified healthcare centers, all 11 Indian Health Service units, 9 of the 11 community mental health centers, and 80 other clinics, like private clinics like Sanford or Avera or Brown or regional health clinics. We had one new clinic in January of 2019, and that was the Regional Health Hot Springs Clinic. We also had 3 disenrollments on December 31st, and that was Centerville, Viborg, and Parker. They didn't have enough individuals and they wanted to focus elsewhere, was their explanation. So I want to share with you some of the performance measures that we have. So this is working into the 6th year of the program. And every year our data gets a little bit better and a little bit better. So I wanted to share with you some of the information that we have on our current dashboard, as well as the link to that dashboard if you want to spend more time looking at it. And so in this instance, this is our calendar. So we work with a calendar year for this program because it's just much easier for us then to get information ready for legislative session by the beginning of January, and because of claims run out. And so you see in the bubbles there that's our average age is 44.2, 60% of our enrollees are female, 59% are in the age blind and disabled category, and the average number of conditions they have is 4.1. And then that small bar down below is the breakout by age. And so you can see that predominantly our individuals, I almost can't even see that, 14 to 20? Or is it, no, it's 21 to 64. So that's 62% there is at age 21 to 44. And then we have that. So that's our age breakdown. So throughout the past 2 years, this program has helped to avoid $7.7 million of Medicaid costs. And so we are very excited about this. This is the second year in a row that we've managed to cost avoid that much money for the South Dakota Medicaid program. So we feel like ultimately it's saving South Dakota Medicaid and taxpayer dollars. But in turn, we also want to make sure that we are providing or improving their health, because that was the second goal. So this is, again, talks more about cost avoidance. So when we looked at that $7.7 million, you can see on the left-hand side, the bar shows the percentage of individuals in Tier 1, Tier 2, 3, and 4, and then the cost avoidance associated with them. So I want to take a minute and explain to you why Tier 1 is so small. So we have two different methods of enrolling this individuals in this program, and it really goes on two separate paths. So a Tier 1 individual has all of the conditions that are required to be in the program, but they're very well managed. So you might have diabetes, but your average hemoglobin A1C is less than 8. Same thing. So you're not going to the ER, you're not on a lot of medications, but your conditions are controlled. They then will be a Tier 1, and they get a letter, but the letter requires them to opt into the program to participate. And so they have to call and say, I want to be in this program. And then the Tier 2 through 4, we handle a little bit differently. So we say you're in until you're out. So Tier 1 is you're out until you say you're in. Tier 2 through 4 is you're in until you say you're out. And so then you can see we really wanted to focus our efforts on those individuals who were the sickest. And so that's how we accomplished doing that, by focusing our effort on Tier 2 through 4 individuals. So the next set of slides are some of our outcome measures based on, again, it's pretty small in here, and so I'm going to flip through these fairly quickly, and then at the end there is a link that you can click on to review it better. And so this first one is for severe mental illness, the number of prescriptions filled within 85%. And as you can see, for those 3 years, we continue to see improvement with our health home recipients. The next one is we wanted to see an increase in screenings and then an increase in referrals for treatment if necessary. So we've had some mixed success over the last 3 years with that, and then this referrals one is really just a kind of a 2-year comparison. Depression, the same thing, screening and follow-up plan. So what do we see in terms of whether or not individuals are actually getting those depression screens? And if they are positive, is a follow-up plan created so that they can work on that? The next one is in focusing on our diabetes and skeletal, so musculoskeletal and low back and neck conditions. So there are two different ways that we looked at the measures on the slide. So that first one where we're looking at diabetes, it takes individuals based on the length of time they have been in the program. So you see that first blue is individuals who have been in the program 1 year. And then the second one is individuals who have been in the program 2 years. And so it compares those two measures, whether or not they had an increase in individuals with hemoglobin A1C under control. And you can see, again, that based on the results that it's gone up and then gone down and then gone back up. And same thing with the individuals with their blood pressure in control. So they have to have a diagnosis of diabetes, and then we evaluated them based on the length of time they've been in the program. And so I feel like what we've seen in measures what we look like this is that typically the longer the individual's in the program, the better results that we get. The one on the right-hand side, the skeletal and connective disorders, was one that we have looked at through our outcome measures. So there's a set of outcome measures that health homes need to report to us. And so this one is, if you have a diagnosis of chronic pain, do you have a pain management plan? And so you can see the different results there. Again, on both of these, this is looking at the length of time that individuals have been in the program, and we're looking at, on the left-hand side, an increase of individuals with their blood pressure in control. On the right-hand side, we're looking at increase of individuals with their BMI under control. So you can see while you have mixed results in the with their blood pressure in control, we do see that every year an individual has been in the program that we continue to see an increase where their BMI is under control. So there are several success stories here. I'm just going to walk through them very quickly because I'm sure I'm approaching the end of my time. So this is, and I know that some of the individuals who presented these health stories to me are on the line, so thank you for giving them to me. So this was the recipient who had diabetes that was non-compliant due to the inability to read or comprehend material. The health home care coordinator was able to pick up on that literacy issue fairly quickly and explored options to help the recipient with his insulin injections, medication, diet, and exercise. So some of the examples of things that they did was they set him up with a pharmacy that did bubble packs, and the bubble packs had the time, and they gave him a digital clock so that he could correspond the time with the bubble pack. They provided the recipient pictures of food that they can eat and what time by showing a sun rising or setting, and what the plate should look like. They did repeated demonstrations of how to check the blood sugar. They had the recipient come into the clinic every 2 to 4 weeks, and as a result, the hemoglobin A1C decreased from 11 down to 7, and emergency room admissions declined, and there have been no hospital admissions. So, I mean, I think just sometimes understanding who your patient is makes a huge difference. And so here's one more. This recipient became part of the health home program in 2016. At that time, the recipient's BMI was 62, and it was dealing with hypertension, uncontrolled diabetes, sleep apnea, reflux, hyperlipidemia, depression, and anxiety. At the time, the recipient was not working due to their poor health status. The recipient started working with the health home and helped the recipient improve mental health, which then led to the motivation to improve physical health. The recipient did receive a gastric bypass in 2017, and as a result, has seen improved health. So this recipient is now working part-time. The diabetes is in control and is not on any medication. All other conditions have improved and are controlled. The recipient's BMI is now 46. The recipient continues to work on wellness and weight and improvements and has seen great improvement in health and well-being and is grateful for the support. And just one more, and then we'll move on. So this health home recipient was morbidly obese and spent a large amount of time in the hospital. This individual spent a lot of time on our follow-up list here within the Department of Social Services, over 7 days. And the recipient was unable to be discharged from the hospital because no physician would agree to care for the patient. So the health home team agreed to make monthly home visits as needed, and the recipient has been out of the hospital since that time and is working with the team and her spouse to take charge of their care, and the recipient's happy to be in their own home. So again, the full results of all of our outcome measures and our financial analysis is available on our health home dashboard found at that link, and it's for calendar year 2017. So please feel free to go out there. There's a white paper that we write every year. And so one of the exciting things that we got to do this year is last year the legislature provided us just under $1 million to reward health homes for the performance during the 2018 legislative session. And so we took 50% of those dollars and we put it towards rewarding everybody and incentivizing everybody by increasing the PMPM around 16%. That took effect for the January through March 2018 quarter. Then we had about $500,000 left to implement a quality incentive payment. And so we created a group that worked with us to create a methodology to help us make these payments. And so we did a base payment for clinics with an average caseload of 15 or less to incentivize participation. Some of those, we have a lot of those in our state, and it's hard to keep this program going in those smaller clinics financially. We also then used their outcome measures as it relates to a state average and created a formula to reward them based on their outcome measures and their case mix, rewarding all different levels of tiers based on the severity. So here's my contact information. If you have any questions, please don't hesitate to contact me again. And I am now open to take questions, if you have any.
A reminder, you can push *6 to unmute your phone line. Otherwise, feel free to type in the chat box as well. And you will have a chance to ask questions again at the end, so feel free to think of them while we move on. So thank you, Kathy. It sounds like participating in Health Homes is a really great way to positively impact our patient care. To those success stories, that's really wonderful.
Thank you. And
Yes.
Thanks for the opportunity to share.
Yes, great. So now we're going to hear about another successful team-based care model currently being implemented in South Dakota, and that is centered medical home. Today, Lori Thomas will talk about reasons to utilize a PCMH framework, including the effect on patient care and the role CHAD plays in these facilities. Lori joined CHAD in the Sioux Falls office in October of 2017 as the clinical quality manager. She brings with her a strong background in both bedside nursing and clinic management. She was an obstetrics nurse for 5 years, and for the last year served as a clinic nurse manager for a community health center in Nebraska, where she developed a strong passion for working in community health centers. Lori's role at CHAD is to facilitate and manage clinically related networks and support quality improvement and clinical measurement activities with assessment, evaluation, and feedback. She serves as a resource and provides training and technical assistance to all health center staff on clinical quality issues and services. Lori, thank you for agreeing to speak with us today, and I will turn it over to you.
All right, thank you so much, Rachel. Like she said, my name is Lori Thomas, and I am the Clinical Quality Manager for CHAD. And I am asked to present today on a team-based care framework called Patient-Centered Medical Home. Although I work specifically with federally qualified health centers in the Dakotas, this model of care is not strictly for FQHCs. Private practice in any primary care clinic can also apply to receive this type of recognition. Now, normally when I talk about patient-centered medical home, it is over 3 days and deep dive nitty-gritty with people, or I can sum it up in like one sentence. So doing a 20-minute presentation, I hope that I don't confuse everybody too much, but please feel free to ask questions, type them in throughout the presentation. But overall, NCQA recognized patient-centered medical homes deliver high-quality care that research has shown can lead to lower costs, improved patient experience, and better health outcomes. So that is what it is founded on. So NCQA is what I just referenced. It is the National Committee for Quality Assurance, which is a super long name, so I'm going to just continue to call it NCQA from here on out. What they do as an organization is they point the way to healthcare that science says works. They study how well health plans and doctors provide scientifically recommended care and make sure that they're doing evidence-based practices. They also identify organizations that are run in a way that make care better. And they also, which is very important, is use measurement, transparency, and accountability to highlight top performers and drive improvement. So that's why they developed different recognition programs, is so they can really highlight those top performers. So different programs that NCQA recognizes, they do recognition programs for HEDIS, health plan accreditation, and patient-centered medical home recognition. NCQA was actually the first evaluation program in the country that is based on this patient-centered care model, and they came out with this program in 2008. The foundations of patient-centered medical home. So it's a model, it's a team-based care model that puts the patients at the forefront of care. Patients surrounding your care around those patients is really what drives this whole model. That's right in the name, patient-centered. So that's what they make sure is happening, is that the patients are at that forefront of the care. It also builds better relationships between patients and their clinical teams. When you put that patient forward, you're really working in that team-based arena, which does provide better relationships. So the research that shows that PCMH improves quality, improves the patient experience, it increases staff satisfaction, and reduces healthcare costs, which I think that we all know that team-based care in general does all of these things in general as well, especially increasing that staff satisfaction. You're not running around doing, random tasks. You really get to work at the top of your licensure. So practices that earn recognition have made a commitment to continuous quality improvement and patient-centered approach to care. So it's not just a recognition, you get it one time and then you celebrate, woo, you're done. They really are dedicating themselves to continuously improve their quality of care. So why become PCMH recognized? For all of these reasons, and I'm going to go over each one of them individually here. It reduces fragmentation in care. So it really emphasizes that team-based care. It has increased communication, increased care coordination, and all of these things lead to better care. It aligns with payers. So many payers acknowledge the PCMH recognition as a hallmark of high-quality care. And a lot of payers are also providing incentives for NCQA recognized practices. So while in the Dakotas, we don't have any payers that yet recognize NCQA and give them incentives, the rest of the United States, a lot of the payers are saying, okay, we notice and we know that NCQA may hold you to a high standard of quality care, and so we are going to incentivize you just by having that recognition and distinction. It improves satisfaction and decreases staff burnout. And 83% of patients being treated in the patient-centered medical home stated that they have improved health and had an overall better experience. Now, I feel like that's a pretty bold statement that they're having a better overall experience, but it's for these reasons right here. So they're able to manage people's conditions and chronic conditions, even acute, better than if they're not. They have patient-centered goals, team-based care, all the disciplines are being on the same page, and they have increased communication between referral sites. So I think that these four things are really why patients express that they're having better experiences at their medical home than other places. One of the standards that you have as PCMH recognition is your ability to communicate with outside referral sources. And so as a patient, when you get referred to a specialty practice, you have a lot of anxiety anyways, knowing that you might not be, something might be wrong and that's why you're going to a specialty. But when you're PCMH recognized, you're saying that you have the ability to share care plans with that specialty, same thing in reverse. They share with you results. The patient doesn't have to call 6 different places to, get the results. They come to your medical home, and your medical home is who you talk to. They align with state and federal initiatives. I think that this is perfect with Kathy's presentation on health homes. They are really aligning with the same programs. Like a lot of the criteria that Kathy had stated is for health homes also is for PCMH. So they looked at different state and federal initiatives for quality for payment reform when they were developing those initiatives and really aligned those with those programs. And PCMH recognition is associated with overall healthcare costs. This is because when you have recognition, you have to identify a high-risk population to do full care management on. And this, again, aligns with health homes, is you have that high-risk patient who is, your high-cost percentage of patients, and that's who you're really doing risk management on to reduce those healthcare costs. Another key component to PCMH is they emphasize the use of alternative appointments, which I know I appreciate as a patient. It is a requirement if you are going to be PCMH recognized that you have after-hours appointments, which could mean you're open from 7 to 8. Some of our health centers do, they're open until 8 at night on one of the weekdays, or they have Saturday appointments. It's really all about increasing that access to patients and to healthcare when and where they need it. This can also mean using a patient portal. In 2019, I hope that most of you are all on a patient portal and know the convenience to having that. You can see your lab results right there. You can make appointments. You can ask for a med refill, all of those things. So that really is emphasized in the PCMH guidelines as well. So here's the muddy PCMH process now. And I'm going to show pictures and examples and go through these as well. So I hope that I don't confuse people too much. But I'm going to say health center just because that's who I work with. So when a health center wants to become PCMH recognized, NCQA puts out a guideline book that's about 80 pages long and wonderful to read. And then also they do different conferences throughout the year where they go over all of the key criteria and content with you and show possible examples and just tell you all about the process. And then if you aren't already recognized, this is a time to really go back and evaluate your practice and say, okay, I would love to be known for, making an impact on quality at our health center. What are some things that we need to change in our health center before we can be recognized? So the guidelines act as almost a policy manual for your health center as well. Once you've decided, all right, we're going to go for it. I want to really make sure I want to be recognized. I want to be known as the gold standard of quality health care. You enroll online with NCQA, and once you enroll, you have 1 year from that enrollment to then go through all the rest of the process to be recognized. So once you enroll with NCQA, you are assigned a reviewer. Okay, so they're an expert reviewer, and you have a kickoff call with them, and they go through everything that you're going to do. So they do 3 virtual reviews with you, where during those reviews, you have to show evidence of everything that you're stating that you're doing. So there are 40 key core criteria and 25 elective criteria that you have to meet and show examples of quality care in order to be recognized. So during those 3 virtual reviews, that's what she's going through, or he. And then you hopefully at the end of that year submit for recognition and earn it and be super excited because it is a lot of work. And then once you have become recognized, it switches over to annual reporting. So like I said before, once you get recognized, it's not just we're recognized and now we're done. You're committing your practice and organization to continually strive for quality improvement. And so every year then, NCQA does a virtual check-in with you where they will have you show random evidence of different key criteria. So there are concepts, criteria, and competencies that you have to prove in order to become recognized. Okay. So the PCMH concepts, there are 6 overarching themes of the patient-centered medical home, and you must show evidence in all 6 concept areas in order to be recognized. So the 6 concept areas are team-based care and practice organization, knowing and managing your patients, patient-centered access and continuity, care management and support, care coordination and care transition, performance measurement, and quality improvement. So those are your 6 umbrella concept areas. So this top part right here that says team-based care and practice organization, that is that key concept. So the practice is going to provide continuity of care, communicates roles and responsibilities of the medical home to patients, families, and caregivers, and organizes and trains staff to work on to the top of their license and provide effective team-based care. Okay, so there's a concept. Now, the competencies categorize your evidence. So criteria is another word for evidence. So you're going to prove to them that you are able to do these things. Okay? So the competency is the practice is committed to transforming the practice into a sustainable medical home. Members of the care team serve specific roles as identified by the practice's organizational structure and are equipped with the knowledge and training necessary to perform those functions. Okay. Last thing is the criteria or evidence that you're going to show during your reviews. So underlying those umbrella concepts, there's activities for which a practice must demonstrate satisfactory performance to obtain NCQA PCMH recognition. And so you can't just submit random evidence that you think is showing that. They have to also agree with you. So everything that you're submitting should be developed from evidence-based guidelines and best practices. And so a practice must pass all 40 key core criteria and 25 elective criteria credits. So back to this not like super confusing, right out of the manual picture, your concept, team-based care, your competency, and now the part that says PC01 core is your evidence. So the guidance part tells you, that it gives you, well, guidance on what the evidence is it's going to have to show. And so it will give you, it will say details about a clinician lead and details about a PCMH manager. So what you're actually going to show them then is the job description of both of those people, and it has to state in there that they are dedicated to PCMH transformation within the organization. So those are the steps for recognition. Clear as mud, right? So nationwide success. Over 13,000 practices are recognized with about 67,000 clinicians. And over 100 payers are now supporting PCMH through financial incentives. South Dakota. Now, this number looks small, I know. So there are 5 practices recognized. We technically only have 4 federally qualified health centers in South Dakota, which each have extension clinics. So that's why Kathy has more federally qualified health centers enrolled. So there is more than 5 clinics that are recognized, 5 total practices that are recognized within Dakotas. Nationwide, North and South Dakota are a little bit behind everybody else just because we don't have very many programs in the Dakotas that are paying for value-based at this time, but we are getting there. So Chad's role. So what is my role in this whole mess of stuff? We have 2 staff that work on recognition with clinics, myself, and then we have Becky Wall, who is a content certified expert. I am also going to sit for the exam here shortly. But we help health centers understand the PCMH guidelines and evidence. We help them transform their practice and attain recognition. So we do that through doing deep dives and mock check-ins with them. So we'll go on site to the clinic and we will watch their clinic workflow. We'll see how they do their huddle. We'll see how they're charting. We'll see the alerts for, different things that they have in their chart. and then we just do a full assessment of what we think needs improvement at their clinic and what they're doing good. And then we have mock check-ins where they upload evidence to us, and then we review it and say, yes, this will work, no, this won't work, all of that type of stuff. Also, I run a quality improvement program for CHAD, and so I make sure then that our quality improvement program has parts of patient-centered medical home built into that, and also any kind of payment reform type of incentive as well. So we're aligning our quality improvement program also with the Medicaid Health Home. So it's my job to kind of take a landscape view of all of what's going on in the Dakotas and try to make those all align with our health center's quality initiative. So my final thought for the day is that team-based care is an integral part of not only patient-centered medical home recognition, but also imperative to attaining advanced access and primary importance when working on clinic flow, improving chronic care management, and addressing preventative screening and follow-up. Does anybody have any questions at all? And if not, feel free to always email me as well or give me a call. Although I work with CHAD and federally qualified health centers, we also can provide assistance for patient-centered medical home recognition to any kind of practice. So it does not have to be a federally qualified health center for us to help you.
Again, you can type your questions into the chat box or push *6 to unmute your phone. Okay. Thank you, Lori. Some really great information on this model, too. As you've heard today, health homes and patient-centered medical homes are two popular examples of team-based care. There are other ways to incorporate care as well. These models can either be formalized or simply involve putting processes into place to incorporate team-based care principles into an organization's practice. Some examples of the more formal models that we didn't discuss at length today are listed here on the left, such as the federally qualified health centers, which Lori referenced. But if you're looking for a place to start, you can integrate team-based care principles into your organization in a relatively straightforward way. One way is to use warm handoffs, for example, to transfer a patient between members of the healthcare team. Typically, one member of the healthcare team would introduce another team member to the patient, explaining why the other team member can better address a specific issue for that patient. For example, a clinician may do a warm handoff to a behavioral health provider or pharmacist, depending on the patient's needs. And this helps to engage the patient in their own care and facilitate effective communication with team members about the patient needs. And another way to take steps forward towards integrating team-based care into your practice could be making an effort to include more members of patient care teams meetings, or to include them more frequently, everyone in the loop. And there are several examples of integrating team-based care through less formalized methods in the team-based care toolkit. Now, I know you guys had the opportunity to ask questions before and we didn't have any, but I just want to take a second again to offer you that opportunity in case you had anything from either of the presenters or anything in general related to team-based care that you'd like some feedback on. Also, if you have any examples of how you utilize team-based care within your own practice that you think might be helpful to the group, we'd love to hear that as well. So you can go ahead and type into the chat box or press *6 to unmute your phone line. Okay, So before we wrap things up, I'd just like to briefly mention some additional resources available on team-based care. First is the online team-based care toolkit that I just referenced that has the examples of more team-based care examples. And this is a pretty comprehensive resource that we designed specifically for our South Dakota healthcare environment. The toolkit describes team-based care in general. It talks about the different models being utilized, including the ones we discussed today, and also real-life application strategies. So this is a really great resource to help you learn more about the different models that Kathy and Lori discussed today, and to access some tools to help get you started if this is something you'd like to look into more at your. So we hope that you'll be able to incorporate something from the toolkit to either implement, improve, or expand upon the team-based care within your own. I also wanted to mention that there will be 2 more webinars focusing on team-based care coming up in the next couple months. So we'd like you to plan on joining us for those as well if you're able to. You can find this information under the webinar section on the toolkit website. Otherwise, through the links posted on your screen right now. Registration is listed there for each of the dates separately, and then the recordings will also be posted to the site soon after each presentation. So as you can see, we have our next webinar on February 13th. And it will feature a panel of professionals utilizing team-based care and will provide some insight regarding patients and providers' perspectives. After that, the March 13th webinar will wrap up the series, and it'll take a look at the real-life application of team-based care, particularly as it relates to our rural healthcare environment in South Dakota. And we are already working with several different facilities and individuals, facilities, analysts, and I think there's going to be some really great information for you on those. Also, I wanted to include, it's not on the slide here, but we are working on quality improvement webinar series as well. And our first quality improvement webinar will be held in February. And we will have Kathy Mueller talking to us again about a little bit about how quality improvement plays a role with return on investment, and related reimbursement, tying all that quality improvement stuff together. And we will also have Dr. Preston Renshaw, who is medical officer for Avera Health Plan, and he will be talking to us about that return on investment, quality improvement as well. There will be more information coming out regarding those websites, those webinars. So be on the lookout for emails, and please reference Heart Disease and Stroke website on the Department of Health website for more information as well. In closing, I'd just like to thank you for joining us today and for your interest in expanding and enhancing team-based care, also for all the work you do to keep our South Dakota residents healthy. If you'd like to find out more about this toolkit, or if you're interested in Cardiovascular Collaborative, which helps in the development of the toolkit, or even if you'd like to discuss potential opportunities to partner on team-based care, please feel free to contact me using here. Again, thank you for joining us today. If you do think of a question at a later time that you wanted to ask, please feel free to reach out to me at the email address or phone number listed again. And we will be getting this webinar posted to the DOH site soon, and I will email out recordings to everybody that registered. Thank you, and enjoy the rest of your afternoon.